So thank you very much, and I appreciate the opportunity to come here to talk about our work. I should just let you know I had the worst flu of my entire life last week, and my throat is hanging by a thread, let's just say. But you can tell from my last name, I'm Spartan, so Spartans were really tough. And my wife says Spartans also have six-pack abs. But I have them too, but it's covered with cake and cookies. But here's some wine. But I've been told now that I'm supposed to cut out all that sugar and meat and everything. That ain't gonna happen, but we'll try. So today I'm gonna talk about some of the work that we're doing in our laboratory at the Ottawa Hospital Cancer Center. But first I'm gonna talk a little bit about the center itself and some of our funding opportunities, because I think it's important for us to realize and thank the Motorcycle Ride for Dad for helping us out and steering us towards doing prostate cancer research at our center. So the two projects I'm going to talk about are some new treatment strategies that we're developing, and also looking at biomarkers, mostly of chemotherapy response. So patients that need chemotherapy later on, we want to come up with new markers to assess whether they will benefit from these chemotherapeutics. You know, the chemotherapeutics have a lot of toxicities, so you want to have benefit without the toxicity. So identifying those patients that would benefit, and identifying, importantly, the patients that won't benefit is actually something that we're really focused on in our laboratory. So I just wanted to start off by highlighting our cancer center. It's actually kind of a unique place. So this is like the new version. We added on to the final version. I don't know, most of you have been here and you're very familiar with it, but you might not notice something that we noticed. In our cancer center, the patients are seen on the first floor. The laboratories are on the third floor, and all the doctor's offices, the med-oncs, the rad-oncs are on the second floor. You can't go to the research floor without walking through the patients and seeing the patients there. I think that is a very important part of our looking at why we're there. Every morning we walk through the patient care facility there. We also have to go through the elevator. We meet with the med-oncs and the rad-oncs and the surgeons that are working there as well. And on the third floor we have the research floor. So we're very interactive. And this really fosters our translational research. If we find something in the lab that we think has potential in the clinical, our colleagues are right downstairs. The patients are one floor further down. This is a very important center. When I was giving a talk at the Motorcycle Ride for Dad at their launch, I said that if anybody wants to tour the place and wants to see the research labs, we're more than happy to have you come by and have me or somebody that works with me show you around and show the facility to you, show the research labs. And they actually took me up on it. And we had about 15 people coming through on a tour. So I'm offering that to you as well. If anybody here wants to come by, take a look at the research lab, see the kind of work that we do, go through the center. There's some parts that you probably won't see when you're there visiting. We're more than happy to do that for you. Now, I might not be the one doing it, but we'll arrange for somebody to come by. Another important thing is our funding support. So I'm not a prostate cancer researcher. I work on pathways that are applicable to prostate cancer as well. And part of applying those to prostate cancer is having the funds to be able to do that. And we've been partnering with the Motorcycle Ride for Dad now for 7 years. And they funded research projects, and the projects I'm going to talk about are partly funded by the Motorcycle Ride for Dad. They've actually put a bolus of money in right now to come up with an acronym we call RIDE. It's the Ride for Dad Effective Research Team, where we put together the people on the second and the third floor. The radiation oncologist, the medical oncologist, the urologist, the pathologist, and the basic scientists are myself and Christina Addison that are involved in this project. I know some of you have mentioned some of these people in our circle, and you can see that they're part of this pathway as well. Like Dr. Morash is part of this group as well. And we meet and we discuss projects, and if they have a project that requires laboratory assistance, we provide that. If we have projects that require clinical assistance, they provide that too. So this is actually kind of a unique setup again, where we have this group that is very functional. So please, if you have any questions as I'm going along, just feel free to ask. We don't have to be that formal here. So what we do, so I started a project almost 25 years ago. And what we've done is, we're looking for novel treatment therapeutic strategies. And, this is a bench-to-bedside approach, I think that many of you have heard about, where we go to identifying a target or a drug, and showing the laboratory assessments that it's interesting. And then following it through clinical trials in the bedside. So we run clinical trials. So the clinical trials are usually, they come in different phases. So phase 1 is an early trial that we're just looking, it's usually a first-in-man study where we're looking to see if there's toxicities associated with this agent. Then the phase 2 is looking more for whether it works, and phase 3 is comparing it to what's available as a standard therapy. So if you, for instance, if androgen deprivation is a standard therapy, we come up with something else, we would, in a phase 3, we would compare it to androgen therapy, see if it's better or worse. So that's usually how it works. And then the other way is, once you do this bedside approach, it's like, have you come up with something new that needs refining? For instance, if this clinical trial shows that there's some toxicity issues or there's issues with efficacy or whether it works or not, can we come up with a more refined therapeutic approach by going through this loop? This loop, it looks simple, but it's actually quite time consuming. It can take 10 years to go through this loop. So, and then you go through the loop again. So I'm going to describe our loops that we did with our study. So we talked a lot about, many of you talked a lot about diet. So when I first started, I looked at vitamin A and retinoids. So vitamin A and retinoids are actually a vitamin A analog. So this is a vitamin that at high doses can induce tumor cells to undergo differentiation. So they stop growing and they look more mature and they're not as aggressive. And so but retinoids show tumor specificity. They only work in certain tumor types. So it's kind of targeted in a way. So, I'm sorry, I keep pressing the wrong button, but they're in many pediatric cancers, some leukemias and head and neck cancers, they actually respond pretty well to high dose retinoids. The problem with retinoids is that they're very toxic. You can't give them at these high doses for very long, and your body and the tumors can become resistant to them. So when I started my research, I was interested in retinoids. I wanted to see how retinoids are working, which pathway are involved in, like what's driving their effects, and whether we can come up with a different strategy that can overcome some of these toxicity and resistance issues. So we spent quite a bit of time trying to identify the targets of retinoid action. We came up with this enzyme, HMG coenzyme A reductase. Now, I'm going to talk a little bit about this pathway. This is the mevalonium pathway. I'm sorry, it's cut off a little bit, but this is a very important pathway. It actually drives cholesterol synthesis in the body. So statins are a class of drugs that target retinoids. I'm sorry. So I see this is cholesterol there. So it's one of the most highly prescribed drugs in North America. Some of you must be on statins. I mean, it's extremely common drug. I'm on it too myself, by the way, so it's not anything. Oh, thank you. Oh, that's great. So now I got to go through. Oh, okay. Good. Oh, this is on. Okay, fine. So you have cholesterol that's being formed in this pathway, but many of the other products of this pathway can drive cell growth or tumor cell growth. So we were very interested in looking at this pathway as a part of this path of this thing. So like I said, statins are very highly prescribed. One of the side effects of statins is they give muscle problems in some patients. So you'll get muscle weakness, you'll get muscle deterioration. But what we found was when we gave it at high doses, like 10 times the cholesterol lowering dose, we were able to target proliferation and basically target the tumor cell. There was a study back in 1996 where they looked at high-dose statins in this way, but the tumor types that they looked at weren't the ones that were retinoid responsive that we were interested in. And so what we did was, well, can retinoid responsive cancers are targeted by statins or not? So basically, yes?
Retinoid responsive, can you miss?
So certain cells are responsive to this vitamin A. So so they have a receptor that binds to. Not all cells will have the receptor. So certain types of, so the pediatric, the myeloid leukemias and the squamous cell carcinomas, their parent, the tissue that it comes from have the receptors, but not all the tissues do. So they're very specific for those tumor types. But they didn't look at it in those tumor types that we were interested in. So here, this is just an assay where we look at cell viability or cell response. So 100% means the cells are all happy, they're growing, they're great. At the lower you go, the more you're killing them. So this is just a viability assay. It's a 2-day assay where we tried our drug lovastatin, which targets this pathway. And you can see most tumor cell lines that we looked at didn't show much of an effect. But there was a subgroup where you could kill all the cells within 48 hours with this drug, and it's very specific. And it was only these retinoid responsive cancers that were kind of sensitive to this treatment. So, to make a long story short, we did 2 clinical trials when I was in Toronto. One in leukemias, as you would expect, and one in squamous cell carcinomas, which is the head and neck patients. And what we were able to show was that, so we had one very dramatic response in one, and we had 6 patients in the leukemias. We had one extremely, so these are all, this is a phase 1 study. These are all patients that have failed all of their therapies. They're basically palliative at this point. They don't have any other therapeutic options. So this is a patient that was in that case, and these are their blasts, their leukemia blasts in the blood. And you can see when we treated with lovastatin, the blast cells stopped growing. There was no indication, and this is for over 100 days. This is pretty well unseen in this type of patient. These patients usually will crash and die within a few days. So we were able to show this, and the patient showed that recurred. We treated again, it went down, they became resistant, and they passed away pretty quickly after that. But at least we had 150 days of them being on treatment without really any potent side effects. However, the next 5 patients that we put on showed this muscle toxicity, and they had to be taken off the study. So we had a problem with the treatment of leukemias. Then we went to the squamous cell carcinomas, which were, the patients there had solid tumors. They didn't have a tumor that went through the whole body, and so they were a little bit easier to treat. And what we were able to show with these patients, we looked at 26 patients, 5 of them showed this stable disease where the tumor stopped growing for an extended period of time. This is 100 days. Again, these are patients that without therapy, these are under palliative care, they don't usually survive more than 3 months. So we had patients that were on study for a year. We had one patient that was on for over a year on this high-dose statin regimen. So that was pretty interesting. So based on the trials that we ran, so like I said, we'll go through this loop where we identified a target. We did the laboratory study showing that it had some kind of potential. We did our phase 1 trial, and from the trials that we ran, it was really clear that using statins would have to be with combination with another active drug. As a single agent, it doesn't look like they're going to be showing much activity. So we needed more activity, less toxicity. So we thought, well, what are we going to use it in combination with? So we did it in 2 different ways. We assessed every known drug that had activity in the tumor types that we were interested in, which was basically the squamous cell carcinomas. And we also did a library screen to identify new agents that maybe wouldn't have been appreciated at that time. So what we did was we did a high throughput screen. We looked at every single FDA approved drug, whether it was a cancer indication or for any other indication. There's 1,200 compounds that the FDA has approved. So it could be antipsychotics, it could be diabetic drugs, it was anything. The reason that we did that is if we wanted to combine agents with statins, having an agent that's already been approved would be easy to do a combination with. Coming up with a novel agent would be much more time consuming. So we thought this would be the way to go. And what we found, I'm not going to put a lot of data into this, both approaches that we used came up with the same drug. So we were very pleased with that. So this is like that this is the assay I told you about. This is the drug alone. It's a erlotinib or gefitinib, which is an epidermal growth factor receptor. I'll talk a little bit about that. And what we found was when we combined the 2 drugs, we saw a very dramatic synergistic or combined effect. This combination worked extremely well. This is the screen that we did with a 1,200 compound. Only a few drugs actually showed enhancement with lovastatin. Both of the EGFR tyrosine kinase inhibitors came up. Then we did the reverse, where we took the EGFR kinase inhibitors and statins came up as enhancing their effect. So both ways it worked. So this is very potent experiments to show that this combination seems to be appropriate. So I'll just talk a little bit about the epidermal growth factor receptor. Now, this growth factor is actually, this receptor is actually very important in embryonic growth. So when you go from a single cell to a full foreign baby, which is 9 pounds, there's a lot of growth potential in that system. And this actually drives growth and survival in this embryonic tissue. However, tumors are kind of ingenious. They take an embryonic growth factor, they express it, and they can grow, and it drives their growth as well. So, and it's expressed in a number of tumor types, and it's including the prostate, but generally lung and head and neck as well. It's a therapeutic target because it's only expressed generally in the tumor cells, and it's also expressed in the skin. That's why you get the epidermal tag on it. But it's generally very specific, and then, so it's in the tumor and then usually in the skin. So I thought it was a very potent therapeutic target. Now I'm just going to show you a little bit about how it works. It sits at the cell membrane. There's a ligand that binds to it, and once the ligand binds, it drives proliferation and cell survival. So it's a very simplistic system. It's actually quite robust. It's actually a very potent growth factor. So because it's such an important therapeutic target, a number of companies, and it's been quite a large impetus to come up with inhibitors of this receptor. So there's two inhibitors, erlotinib and gefitinib. They've been developed. They've been mostly looked at in lung cancer because lung cancer has this mutation that makes them extremely sensitive to this in about 8% of patients. So it's used in that setting quite well. I'm gonna talk a little bit about BR.21, which is a clinical trial. It's actually one of the most famous clinical trials for these agents. It was done out of Kingston, a pan-Canada trial. It was the first trial that showed that these drugs actually had a survival benefit in a patient population. So we were very fortunate to actually be involved in this study. But what it did is, in patients without being selected for this mutation, it improved survival in lung cancer from 4.7 months to 6.7 months. So it's a 2-month survival advantage, which you think is not great, but in lung cancer, that actually is quite significant. So, and the most common side effect, as you would expect, is because you're targeting this receptor in the skin, you get skin rash. The skin rash, if you get it, is usually a good sign. It means the drug is kind of working. And so if you have a skin rash, your response rate is usually high. So because this work was done in Kingston, I'm not going to take credit for that. I sent one of my students down to Kingston to look through the charts and look to see how many patients in this BR.21 trial were on statins. Because, you know, it's a very well-prescribed drug. It's actually quite interesting because at first they didn't think there would be any patients on statins. These are like late-stage patients, but they still worry about their cholesterol levels, which is good. So they're still on the cholesterol drug even though they were putting on a trial and told, the prognosis is not very good for these patients. Like I said, they're on usually about 4 to 6 months survival is usually what they have. But they still take their cholesterol lowering drug, which is good for us in a way. And what we saw was that in patients that were taking Tarceva, the drug, and that were taking statins, they had a slightly better survival than the patients taking just Tarceva alone or erlotinib alone. And to compare this drug, we looked at another trial where they were just on chemotherapies. And we looked at the patients that were on statins and chemotherapy, and the lines were right on top of each other. There was no benefit in the chemotherapy patients taking statins, but there seems to be benefit in the Tarceva patients. So Roche ran this BR.21. We went to Roche, showed them the data that we were data mined, and they paid for this study, which was a phase 1 study that we did here at the Ottawa Hospital. It's a single center study. They wrote a check for about $1 million to run this trial, which was very, very good for us. We actually had patients that ran on the study. Now, most of the work we did was on lung and head and neck, but because this receptor was also in prostate cancer that's involved in it, what we did with some of the motorcycle ride money that we did was show that prostate cancer cell lines also were amenable to this therapy. That the cell lines that we tested also showed activity with this combination of agents. So we were actually able to incorporate some prostate cancer patients that had failed therapy into this phase 1 study. So 3 of the 24 patients that we had were prostate cancer patients. That would not have happened without the money from Motorcycle Ride for Dad and showing that there was activity in prostate cancer. So I think it's actually quite an interesting and very worthwhile endeavor that we have with Motorcycle Ride for Dad. So this is a phase 1 study. Now I talked a lot about, we used lovastatin a lot. We switched over to another statin that is a little different because erlotinib, the drug that we were using for the tyrosine kinase inhibitor, is degraded by the same enzyme as lovastatin. And when you put 2 drugs together that are targeted through the same degradation pathway, there's going to be some target effects. There's going to be some effects of their metabolism and everything. So we used the rosuvastatin, which is the AstraZeneca drug. It's a little bit better kinetics, but I mean, it was important that so I didn't want anybody to say, hey, why are you switching drugs? We had to switch the drugs because they're contraindicated when they target the same metabolic pathway that they're. So for instance, if we use lovastatin, erlotinib degradation could be affected and it might not work well. So we had to switch drugs that way. So this is the drug, this is the response rates that we saw. Again, we see the same type of thing. Most patients do not respond. This is like the time on study. But again, we had a certain subpopulation of patients that were on study for 300 days. So they were on high-dose statins for 300 days. Patients that generally don't respond well to any other therapy. So they failed every other therapy, radiation, chemo. So some of these patients had 8 rounds of previous therapies before they went on the study. But most of the patients had 2 rounds because the lung cancer patients and esophageal and pancreatic patients don't usually see more than 1 round of standard therapy. We had the GU patients, there's 4 of them, 3 of them are prostate cancer patients, 1 was something else. But you can see that we had these patients. So if you can see it at the progression-free survival, so this is patients that tumors didn't grow. And so when the patients' tumors grow, at this certain days they come off study, so it's a waterfall plot. So you can see that most patients, after about 50 days or 2 months, their tumors progressed. And that's generally typical of what these patients would do. But there was a small population, about 20%, where the patients were on study for a very long time. So we had patients up to almost 300 days, which is a year on study. But for patients that are on this phase 1, that was actually quite a dramatic response.
Doctor?
Yes?
In your second graph,
Yeah.
you have names underneath it.
These are the different
prostate people in one of those?
Yes, the gastrourinary, they call GU.
So
it's a urinary tumors.
Which one? First, second, third?
Well, we had one that did really well.
What?
We had one that did really well.
No, but
So three of the four are prostate. One was some kind of vaginal tumor.
Oh yes. It's the fourth one, GU.
Yeah, GU, yes.
Okay, thank you.
Yeah. So we also had colon and breast. So these are all tumors that have this epidermal growth factor receptor kind of modality with them.
I had a
Sure.
similar question. Crestor, who's your choice? Lipitor, no. Who's Crestor?
So Crestor or rosuvastatin is the one that, so all of them target this certain degradation through this certain cytochrome P450. So like for instance, you're not supposed to take grapefruit juice, say, with some statins, because they target that same enzyme. So erlotinib works with that same enzyme. So you don't want to add two drugs that are targeted by the same enzyme, because you're going to screw up their kinetics. So for instance, say rosuvastatin is blocking that enzyme, or erlotinib gets degraded quicker. We don't want to affect the drug dosing. So we actually done I'm not going to present that here, but we've done the pharmacokinetics and showed that rosuvastatin does not affect erlotinib serum levels. So they're fine. So I think this combination is good. I think what we did show with this drug, even if you don't think that the responses are good, if you're on erlotinib and you have high cholesterol, rosuvastatin is probably the drug you should be taking because it doesn't affect erlotinib at all. Some of the other ones do. So I think that's at least one thing we can show. I mean, I think the responses are interesting as well, but I mean, that's something that, you have thousands of patients taking erlotinib. There's probably a few hundred that are taking a statin as well. And so instead of stopping your statin, you might want to try this one. So one thing that we did see though, that really was a problem with this study, these are the ones that had the muscle toxicity. I'm sorry, they're in yellow, they might be hard to see. But we had about 35% of the patients, over one third have muscle-related toxicities. And that was a huge problem with this study. And that, even though we were getting responses, we were getting quite a bit of muscle toxicity. And so those patients had to be taken off study. And so usually at low dose, you see 1% to 2% of patients having this muscle toxicity. We're seeing 35%. So obviously, we're going to have to refine this approach. So what we're doing now is, so back to this, so this is, I get a 12-year process, like I want to say. So what we did was we identified that these tyrosine kinase inhibitors, the EGFR inhibitors with statins showed synergy. We did our phase 1 trial, and now what we're doing now is we need to replace statins, we think. We need to mimic their anti-tumor effect, but get away from their toxicities. So we have this kind of approach that we're using now. And so I'm not going to get into too much of this detail. Again, what we showed was, so the muscle toxicities are usually due to one of these compounds, of ubiquinol. We're looking at more downstream enzymes in this pathway, so here, if you target these enzymes, you don't affect the levels of ubiquinol, which is probably what's driving the muscle toxicity. So what we're really doing now is looking at these enzymes as potential therapeutic targets. And so we've been able to show at least one of them, the Brown transferase, actually shows activity in combination with erlotinib. So that's generally where the next study is going to come from, we think. It could be something different, but right now we're in talks now with a company that makes an inhibitor for this enzyme and seeing if we can run a phase 1 here again in Ottawa. So this company is a smaller company. It doesn't have the money that Roche does, so we're going to have to probably come up with some of the funding here as well on our own. So the other part of the project is identifying biomarkers of response, and that's usually due to chemotherapy. Now, for me to work on chemotherapy is kind of an interesting side thing, because I always thought my job was to replace chemotherapies. But most of the clinicians I work with, the ones that helped us with the study, they're all saying, we need a biomarker for chemotherapy response. Help us get a biomarker for chemotherapy response. And so I acquiesced a little bit. I said, okay, let's start with that. So what we did originally was, this is a study that we published in 2009. So we started it just before then, and it's not something that, so we looked at a couple of markers that other people have shown were important for cisplatin response. I'll get into a little bit of what we did. And so we looked at basal levels of, so we took the tumors that were sitting around and we looked at their levels of these proteins and seeing if that predicted response to drug. I didn't really like that approach because I thought it was not very, I was more interested, so we did the study. And so some people here in our circle asked, well, what would you do if say you had this BRCA level and someone came to you and one of your family members, should I get chemotherapy based on BRCA levels? I would say no. Do not look at it. This is not robust enough. It's not clean enough for you to decide whether you're going to get chemotherapy based on BRCA levels or ERCC1 levels. Even though we showed that they could predict it, but it wasn't robust enough. So I was under the impression, well, maybe we should take the tumor itself, treat them with these drugs ex vivo in the lab, seeing if they respond to these drugs before we give them to patients. And I was told that that was an impossible way of doing it. It can't be done. I mean, we have to get surgical samples from the surgery suite, bring them through pathology into the lab. It can't be done. I said, well, I think I can do it. So I went and talked to some of our surgeon colleagues. We set up, we went through this was a huge problem. I'm not even going to go into how hard it was to get our review board to agree to let us take surgical specimens out of the pathology lab. It was quite a challenging endeavor. It took us 6 months to get approval, another 3 months to get pathology on board to give us samples. So this is a full year it took us from the time we started to the time we actually got tissue. But now that it's up and running, in the next year we had 100 samples come through the lab from different tumor types. We have surgeons now coming to me wanting to be part of this study. So I think it's really expanding up. We call it, so most of the clinicians I work with like acronyms. So we call this one OTTR, Ottawa Tumor Tissue Resource. So I don't know. So we're funded now through the university. The university actually funds OTTR. And we have about 50 clinicians, scientists, pathologists, and surgeons in Ottawa. So it's actually one of the largest kind of groupings that we have at the Ottawa Hospital, which is good. And I'm the PI on that, so that's, I get all the props because I do all the paperwork. So the goal of our study was to identify these predictive markers by looking at drug treatments in ex vivo, in tumor samples taken from the surgery suite. So the clinical relevance to this is that we want to identify patients likely to respond to therapy, but more importantly, identify patients unlikely to respond, so they can undergo without the toxicity. And if they don't respond to therapy, maybe we could choose another therapy that might have more efficacy, might be more better for them. So if cisplatin doesn't work, maybe they should be on something else. So that's the goal of this study. So I'm not going to go into too much of this, but you know, as we all know, first-line therapy usually involves hormone therapy. If that fails, then you go generally go into some chemotherapy. Usually it's a taxane, like docetaxel. But if that fails, you go through anthracyclines or platins. So anthracycline is like a doxorubicin or cisplatin or a carboplatin. So that's usually how it works. I don't know if anybody here has been on chemotherapy yet. It's usually very late in what we do. So patients that generally fail the other therapies can see chemo, but usually advanced disease. But we do see quite a bit of those patients when we do that. So platins, it is the most widely used anti-cancer chemotherapeutic. It's almost all lung cancer patients, most ovarian cancer patients, and a lot of prostate cancer patients will see this. The problem with this, it has some significant side effects, including nephrotoxicity and some neurotoxicity. This really limits how it's used. The other drug that I'm interested in is doxorubicin or Epidermal. It's also a very important drug. These are the two drugs that have been used since the 70s. They have been very, most cancer patients will see either one of these two drugs. So it's usually in hormone refractory prostate cancer patients that you see this. Advanced disease though, people with metastatic disease. It has an extremely bad side effect of cardiotoxicity. It can cause quite a bit of problems with, so if you actually if you can get through the rounds and have a good tumor response, you have to live with, a lot of times you have to live with the cardiotoxicity that comes with this. This really limits its dose. The way it's given is you follow the cardiotoxicity and you adjust the dose to make sure that the cardiotoxicity is manageable, but the dose is lowered for this drug. So I think, so right now there isn't any real biomarker to show which patients should get this drug or not. So what we did, we took a few of the cell lines that we had, we made them resistant to cisplatin, and then we treated the cell lines with cisplatin afterwards to see what genes or what markers went up or down with on treatment. So not the baseline stuff, we weren't really interested in that. So if we look at this, in the baseline, so this is like looking at a few parental lines and a few of the resistant lines. We weren't really interested in the changes that were in the untreated, sensitive versus resistant. We were only interested in the ones that were upregulated with cisplatin, because we thought that that would be an interesting thing. And we came up with this activation transcription factor 3, which is a very important factor that drives cell death. So if you have a lot of this, it induces cell death. So you can see here, this is just a protein plot showing how much protein, how much ATF3 protein is there. And you can see in both the sensitive and the resistant line, there isn't any when you don't treat with anything. Then when you treat with cisplatin, you see a very dramatic induction or increase in ATF only in the sensitive line. In the resistant line, you don't see any. So we thought this is a perfect biomarker for this type of results where we can get tumor tissue. If we can get tumor tissue, you would expect to see the same type of thing. So this is like an on-off switch, which the other markers aren't on-off. They're like, you look at levels of, so you say, oh, well, that has like 30% expression to 40%. This looks like an on-off switch. It's the perfect biomarker, we thought. When we designed the study, we said, well, what would be the perfect biomarker? And I think we found something that we would have thought would be perfect. So this is just showing some of the prostate cancer work that we've done. And you can see again, an ATF3 is very low expressed in the untreated cells. But as soon as you treat with chemo, it is induced quite dramatically. And so that's something that we're very interested in to see if we can do that. But now this is all cell line work, and that's okay. But does the tumor tissue actually show this type of difference? So this is the Ex-Vivo tumor analysis that we're doing. We take the tissue sample from the surgery suite, we core it and make slices of 2 millimeter by 1 millimeter, so there's enough room for the media that we put in to go through it so that doesn't die on us in the lab. And so, and then we randomize them and then we put them in and we treat them. So this is Khalil in my lab, and you can see he's very happy to do this kind of work. He's not always that happy, by the way. I told him to smile. So you can see that the tumor tissue comes out, we make the little cores, and we put the cores in our plates, and then we treat them with cisplatin. And so this is some of the study that we've done. So I'm just to let you know, for the prostate, it's not as easy as this. Because the prostate, when the tissue comes out, there's quite a bit of normal tissue usually with it. I don't know when you guys get your scores, they're usually 18, 25, 30% tumor. That means there's 70% normal cells in there. And that makes this extremely difficult. So we've had to do a slightly different assay for the prostate tissue that we're getting, where we're looking at individual cells, whether they induce, so we're looking at tumor cells and whether they induce. The reason that we're doing this is that this is lung. And for the lung, when patients go in for surgery, they do full lobectomies. So we get the full lobe out. We get the tumor plus adjacent normal tissue. So that's that is the best assay for us to use. So we've been focusing on that for now. So we have adjacent normal. Oh, sorry. I gotta stop doing that. So we have adjacent normal and the tumor that goes with it. And you can see in adjacent normal when we treat with cisplatin, you don't see any. So this is looking at RNA levels, expression levels of ATF3, the gene we're interested in. In the normal, which is considered drug resistant because normal cells don't usually respond to cisplatin this way, you don't see any ATF3 induction. When you look at a tumor, you see a very pronounced ATF3 induction. Now this happened in 3 out of the, we've done 6 tumors so far this way. In 3 out of the 6 we see this nice induction of ATF3. In none of the normal tissues we've seen induction of ATF3, so 0 out of the 6. So I think this is a very potent way of doing it. And so this is why I presented this work at our rounds, and that's why we're looking at a number of different tumor types. So not only are we looking at prostate, we're also looking at head and neck and ovarian cancer as well, which is a cisplatin resistant thing. The doxorubicin data looks very similar to this, so we're going to be doing that as well. So for the prostate, I'm hoping, well, next time I came here about 6 years ago, hopefully in the next 6 years when I'm back, you're going to hear about this a little bit more in detail, and hopefully we'll have a marker that can predict patient response to these important class of drugs. So this is what we're doing now with the lung especially, is to take biopsies pre-treatment. So patients that are going to go under, we're going to be treating with platins. We're going to biopsy the material, look for expression, and then follow them, the patient themselves, to see if they respond to the platinum and whether their tumor gets reduced directly. So instead of just looking at the expression levels, we're going to actually follow patients and their response. It's a little easier to do in lung because of the CT scans are much easier to do. But that is the way we're doing it because it's the best model. We're going to expand that model into the other tumor types as well. So obviously, I don't do any lab work anymore. So the work is done by the guys in the lab that are listed here. Our collaborators are many of the clinicians that we work with. I didn't put the prostate people because I talked about them before. These are more of the lung guys that are helping us out, and some of the GIs. So Derek is the person who's giving us is helping us out with the prostate samples. He's the one that's organizing that with Dr. Rodney Broke. I don't know if anybody here knows him.
Yes, he presented last.
Oh, did he? So Rodney's part of this Ex-Vivo study. So he's providing us with the prostate samples, and a few other ones, a few other interesting ones as well. So like I said, so the motorcycle-ride-for dad guys are very important in providing us with the research to let us do the work that we do in prostate cancer. So that's very important for us. Well, thank you. I appreciate this opportunity.
Any other questions?
So that tour that I offered is open. Anybody wants to come through, I'm more than happy to take you through.
For those of you who don't know, we have been lucky enough to find a resource that's helping us find speakers, which has been great because we've actually been fairly fortunate to find good speakers on our own, but sometimes it's been difficult. So now we have this person that's at the Ottawa General that's helping us find people to speak. And the other thing you probably don't know is you were not supposed to originally speak here this evening. We had someone else lined up for a couple of months, and then that person couldn't make it. The person that helps us find people said, well, I'll find you somebody else, and she kept asking people, and we ended up with you. And I just want to say that your talk was fascinating, so much so that I can't remember what the other guy was supposed to talk about. So thank you again for coming out on such a cold night. This is a little token of our appreciation.
Thank you.
And I think it's kind of appropriate because it's supposed to be good for the throat.
It's not Greek wine, is it?
No, it's not.
That's not very good.
Thank you very much.
Thank you very much.